So we're continuing our discussion on some of our GI issues, and now specifically we're focusing on intestinal and rectal disorders. And some of this content on here is pretty straightforward, and you may find that it's not that complicated, but you may find that some of the other content might be a little bit more challenging. In particular, the small bowel obstructions. That might be the first time that you're coming across that. There are a whole bunch of different things that can cause constipation. So some of them include things like medications, chronic laxative usage, weakness, immobility, fatigue, the inability to increase intra-abdominal pressure, poor diet, ignoring the urge to defecate, and a lack of regular exercise. And it's well been established that the risk for constipation does increase with older age. And some of that has to do with the fact that maybe the patient may be on a whole bunch of different medications, but maybe the older patient is also not drinking enough water, they're not getting enough exercise, right? So there's a whole bunch of different variables as to why the patient may not be able to go to the bathroom and have a bowel movement like they should be. By definition, constipation is basically an abnormal infrequency or irregularity of defecation. So it's any variation from normal habits that may be a problem. And this varies across patients. So there's such a thing known as perceived constipation here at the bottom. So maybe for our purposes, we say that everybody should go and use the bathroom at least 3 times a day. So they have breakfast, lunch, and dinner, and we're expecting that somebody should be having a bowel movement. But maybe a particular patient believes that they should be going 5 times a day, right? So for them, if they're only going 3 times a day, they may say that they're constipated, because ideally for them, even if they drink water or they have a salad or something, they should be having a bowel movement, right? So, and this perceived constipation is whatever the patient believes it to be. It's whatever they think is normal for them, and regardless of what we're saying should be the normal thing that should be going on. A whole bunch of different manifestations that can happen. So in general, across the board, if we're saying that somebody is constipated, it means that that patient is having fewer than 3 bowel movements per week. So that's pretty bad, right? Because I mean, at least everybody should be having a bowel movement every day, for sure. But people will even say that at least everybody should be having a bowel movement after they've eaten anything. They should be, having a BM. So if we find patients that are only having bowel movements, fewer than 3 bowel movements per week, then that's pretty bad, right? So the other things you may see in the patient include things like abdominal distension, decreased appetite, a headache, fatigue, indigestion, a sensation of incomplete evacuation, straining at the stool, and elimination of small volume, hard, dry stools. And all of that makes sense. So I'm not spending too much time on constipation because I'm pretty sure you already know what this looks like. The assessment and diagnostic findings for this. So we've been told that chronic constipation is usually idiopathic. So when somebody ends up with things like chronic constipation, we don't know what is causing it, basically. That's what this word means here, idiopathic. We're not really clear about why the patient has chronic constipation. The usual types of constipation is, the mild ones, it's usually because somebody's not drinking. Maybe they had surgery and they're not mobile yet, or maybe they need to basically improve their diet, maybe have more high fiber foods, right? So those types of constipations we can usually fix right away, and it's not a big deal. So there's other tests that they can do for severe intractable constipation. So anytime you're seeing the word intractable, it basically means that they're not able to really treat it. So maybe they're trying meds, they're trying diets, and like something is basically not working, right? So then they'll have to figure out, okay, what is going on? Because now you have this patient with chronic constipation, and it's not reacting as it should be to the proper treatments that we normally would be using. So we're looking at the history, the physical examination for the patients. We may be doing things like the barium enemas. We're doing sigmoidoscopies and stool testing, just basically trying to figure out what is going on with this patient, right? The other tests that they can do, which are not responsible for memorizing, so they can do this other one, the defecography. So this one is a patient is basically defecating in real time, and on the toilet, and then they're watching the transit time as the patient is going to the bathroom. All right, so I will give you a handout so you can see what that looks like. But it's essentially the patient is sitting on the toilet, they're going to the bathroom, and then they're taking x-rays that shows the rectum and the anal canal changes as the patient is having the bowel movement. So this helps them to basically figure out, how long it takes the patient to have a bowel movement. Is it too prolonged? Is it short, etc. Then the other tests they can do are also things like the MRIs. If your patient is having things like constipation, you can actually end up with complications. The bigger ones happen to be things like the fecal impactions and the megacolons, right? And we'll discuss some of these later on. But other ones include things like hypertension, fecal impaction, hemorrhoids, fissures, and megacolon. So fissures is primarily because of the patient is straining a lot. So then their lining ends up getting openings, right? You're getting fissures there, right? Because you're straining too hard. So it's almost like they're getting bleeding types of things that are going on. Okay, so just know that even if a patient has constipation, if it's not treated, they could actually end up with complications. So including things like hypertension, fecal impaction, hemorrhoids, fissures, and megacolon. For your patient, you know the things that can cause the constipation. So what are you going to do? You're going to focus on the fact that the patient needs to know what their normal variations of the bowel patterns are, right? So they need to know what their normal patterns are, and then they need to be able to identify if there's any weird variations that are going on for them, right? If anything has changed. And making sure they're getting fiber, fluid intake. Don't hold off to use the bathroom if you have to go. This is something that we're all told. And even as nurses, we hold our urge to go to the bathroom because, we don't even go to urinate sometimes because we're so busy, but never ever do that. Your body is designed to work in a particular way. So respect the urge to go and defecate. Exercising and activity, and making sure that they're not using too much laxatives. Laxative maybe once a month as needed, minimal, fine, but no one should be using laxatives every single day, because then then you lose that tone, like I said, the urge for you to go by yourself. All right. In short, the treatment for constipation is basically treating the underlying cause, right? So this is going to be centered around education, diet, and exercising primarily. Those are like the main things. So guys, for constipation, know that normal for most people is at least having a bowel movement once a day. If they have the best bowels ever, they go at least 3 times a day after they've pooped. But we are considering somebody to be constipated if they're having less than 3 bowel movements in a week. And we're also highlighting the fact that, there are certain things that can cause constipation. So what you need to be able to do is understand what are some of the things that can cause constipation, as we've gone over. And your answer to the question of how do you manage constipation, it is literally figuring out what is the cause and then targeting that. Then moving on into diarrhea. So this is the opposite of that. So this is an increased frequency of bowel movements, so more than 3 per day. So we're considering this one to be diarrhea. So increased amount of stew, more than 200 grams per day, and altered consistency. So there's looseness. So you're paying attention to the of the anus. And then also this weird word, which you do not want to forget, is tenesmus. So this is it's basically like some cramping sensations that happens around the rectal area. So it's basically cramping rectal pain. And the tenesmus, you want to also monitor for it when somebody has the colonoscopy, when they put that tube up to basically inspect, what's happening in your colon as well. After they remove the tube, the patient may complain of like some mild rectal pain that happens because of that. So this, the medical word that they may use is known as tenesmus. So that's a word that you do not want to forget. These are just some of your assessment and diagnostic tests that they may do. So not overthinking any of this, and we're actually skipping this. Your patient that has diarrhea, and all of these should make sense to you as to why they may potentially happen. So lots of diarrhea going on, losing a lot of fluids and electrolytes, what can happen? So fluid and electrolyte imbalances, dehydration, and potentially cardiac dysrhythmias because they're losing a whole bunch of electrolytes. In terms of treatment, making sure that the patient is getting enough rest, looking at the diet and the fluid intake, avoiding any types of irritating foods. So this may include things like caffeine, carbonated beverages, very hot and cold foods, doing a lot of perianal skincare, giving the patient medications to help with the fact that they're having the diarrhea, right? So you may have some medications that I gave you that specifically are targeting the diarrhea. You may have maybe Imodium, or you may have seen commercials where they even prescribe things like Lomotil, loperamide. These are just some examples. So you once again are just focusing on the ones that made it on your list. Okay, can't remember if Imodium made it or not. And so also maybe the patient has to avoid things like milk, fat, whole grains, fresh fruit, and vegetables. And obviously, if you're lactose intolerant, making sure that you're not getting any of the milk products, right? And then the whole reason why you're not using any of these irritating foods like the caffeine, the carbonated beverages, hot and cold foods is because they can potentially stimulate the intestinal motility, right? So they're irritating to GI lining. And different patients will react differently. So not every patient will be irritated by coffee, right? So you just have to see what it is that the patient needs or how the patient responds to particular types of foods, and then you're getting rid of those. If the situation gets really bad, then for sure the patient is going to be needing things like IV fluid therapy if necessary, and that can definitely happen in the older patients for sure. All right, so that's pretty much all we're saying about diarrhea. Then we're getting to fecal incontinence, right? So incontinence is just an involuntary act that's going on, right? So here we're specifically highlighting fecal incontinence. So now, therefore, we're talking about involuntary passage of stool, right? So the patient is sitting down and minding their business, and next thing you know, they get up and their whole bottom is soiled, right? So that was involuntary. They didn't push it out or anything. They're basically incontinent, right? They're not controlling it. So a whole bunch of different things can cause fecal incontinence. And once again, not overthinking any of this. Keep it very, very simple. So things like trauma, neurologic disorders, so a whole bunch of neuro problems where the nerves are basically affected. Maybe it might even be something like multiple sclerosis, right? If it's advanced cases, maybe they end up with something like fecal incontinence. Inflammation and infections, chemotherapy, radiation. If they have fecal impaction, this is where there's such a buildup of the stool inside that normally you want to defecate or you want to poop, and it gets to a point where there's so much junk in there that there's too much pressure that your body is still trying to kind of get rid of some of it, and so maybe you may soil or spot your underwear because Somebody's laughing at what I'm saying. You're underwear because you're just impacted in your body. There's too much pressure in your body. Is trying to kind of get rid of some of it. So you're basically just, incontinent at that point. Ideally, the patient never should have been impacted to begin with. If they're eating properly, proper diet, enough water, we should never get to a point where we're getting this fecal impaction. So once again, remembering the definition. So it's an involuntary passage of stool. So it wasn't meant to happen, right? So there's this buildup that's there, and now the stool is still trying to get out, and it finds its way out. Maybe a patient has had too much pelvic floor relaxation, and now that whole area is too loose. Maybe they've had a baby, right? So there's too much of a pelvic floor relaxation that's happened because of that. Laxative abuse, medications, and another example might be advancing age. So any of these things could be causes for fecal incontinence. As I mentioned previously, so you're going to see things like minor soiling, occasional urgency, loss of control, and then the patient may actually end up with complete incontinence. In terms of your, the assessment and diagnostic findings. So we're doing a whole bunch of different tests once again, trying to figure out, okay, why is this patient incontinent? So what's causing the incontinence? The only one I'm going to mention, which you're not necessarily responsible for remembering right now, is the anorectal manometry. So this one is just basically a test used to measure the contractility in the anus and the rectum. And I'll see if I can find a handout to help you with this one. So for incontinence, once again, in terms of treating it, it's putting the patient on a bowel training program, skincare for sure. If they're getting a lot of irritation, right, they may even end up with mild skin breakdown, and then a lot of emotional support, because this is definitely embarrassing, right? You're walking and, people are telling you that you're soiled or you've soiled yourself, right? So that's a big deal. So the bowel training program essentially just means that you have a certain amount of time that you've decided is a good time to basically offer the patient a bedpan, and you ask them to go, right? So maybe for your particular patient, you said like every 6 hours, you're going to offer them a bedpan to see if they can poop. And so you bring the bedpan and you ask them to go. And the idea is that if you put them on a regimen like that, they will be able to go, and then this soiling won't be happening as much, right? It will take care of the urge. You ask them to poop, and then you come back, whatever the prescribed amount of time is, and you ask them to go again. And you make sure that maybe they've been fed, they've gotten their medications, all those good things. So just put them on a program, very regimented, and you follow it, and you basically stick to it. What else are you doing with here? And essentially, you're treating the underlying cause also applies over here, right? So finding out what is causing the incontinence is very beneficial, and then you basically try to figure out what is the best way to treat this for your patient. So if it was laxative usage, obviously making sure they stop that, right? If it's something like chemo, maybe well, you can't really do much in terms of the dosing itself, but maybe giving some other medications that can counteract the fact that they may end up with diarrhea excessively, and that could potentially lead to the incontinence as well, right? So you're just everything is patient specific, and you're just trying to see what's going on with your patient, and keeping away all the other crazy stuff that's never good, like the food triggers, the alcohol, stress, like all those things are always beneficial as well, right? They're not going to hurt. And then we're going into IBS. So this is irritable bowel syndrome. This affects a lot of people in the United States as well as the world. And another word for IBS is spastic colon. And once again, we're not spending too much time on IBS itself. Main thing is knowing that it is a spastic colon. It's more common in women than men. And then there's certain things that can trigger it, right? So it could be hereditary, psychological stress, depression, anxiety, high-fat diets, irritating foods. This one seems to be a big one. And then alcohol and smoking use, right? So you're trying to kind of see, okay, what is so unique about IBS right now? Why is my colon acting crazy? So maybe this is the first time we're noticing things like psychological stress. We're noticing things like depression and anxiety and irritating foods. Yeah, that's pretty true across the board for all the GI types of issues. And we've already mentioned that alcohol and smoking is never, ever, 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 ever good for any condition at all. So yeah, so this is like one of those, and it's weird because I think like as I've gotten older, I've met a lot of people that are suffering from IBS, and the IBS may show up for sure, like when they are stressed. So that's really interesting, and yeah, so they have to find out what's going on. In a lot of cases, even the people that I've known, their IBS wasn't caused by anything anatomic wise or structure wise in terms of how the GI tract is laid out. Like that's never the issue, right? It's usually some of these other things that are contributing to it. So, but anyway, they'll do the tests basically to see what could potentially be causing the IBS, right? They'll try to rule out the fact that there's no other structural types of issues that are contributing to the spastic colon, in other words, right? So in a regular boring IBS patient, there is no anatomic or any weird biochemical abnormality in the patient, right? And the patient will end up being diagnosed as having IBS after they've ruled out any type of structural issues, any type of anatomic problems. But they'll find that there are certain things that basically trigger this colon to basically start acting in a really weird way. So it's a very, very interesting thing. And you guys can share with me if you know people that have IBS. Okay. In terms of the pathophysiology, so you're getting this neuroendocrine dysregulation. So there's a change in serotonin signaling, infection, irritation, vascular and metabolic disturbances that are basically happening. So serotonin apparently is really an important GI signaling molecule, and it is incredibly important for metabolism. So serotonin is helpful in regulating the growth, reproduction, and metabolism, in addition to a whole bunch of other things that it's doing. So when there's a dysfunction in this signaling mechanism that's going on, then there's a dysregulation essentially. Then this is why the patient may be ending up with the some of these disturbances that we're seeing. So what you're ending up happening is that you're seeing peristaltic waves are affected, including intensity and how fecal matter is moved forward. So it's dysregulated, so it's wacky. It's not, it's not smooth. It's not a smooth transition, and apparently there's no evidence of inflammation. Your clinical manifestations, main takeaway is alteration in bowel patterns. Okay, so the signaling that's supposed to be there is not happening. So the patient with IBS can actually report that maybe they have constipation, or maybe they even have diarrhea, or they're having both of them, like they're going in between the two types of GI alterations. All right. Some of the patients will report pain, and this can be precipitated by eating and relieved by defecation. Things like bloating and abdominal distension, all of those things are possible for IBS. So your main takeaway is that the regular metabolism, and remember when I use the word metabolism, it's making things useful, so making things work properly, right? So serotonin is supposed to be, regulating all these different mechanisms of metabolism, and that's no longer happening. So then you're just getting this wacky dysregulation that's happening. The assessment and diagnostic findings, the tests, so all of these can potentially be done, and you are once again focusing on the ones that made it on your list. Colonoscopy, I believe, is one of them, and if you've never seen this word before, the proctoscopy. So for this one, it's basically they're looking into the anal cavity, the rectum, and the sigmoid, right? So they're looking around to see what is happening over there, right? So just know that all of these tests are out there, and they can be used to diagnose a patient with IBS. Moving right on along, so it's going to be either, in terms of the treatment, what we want to do is relieve the abdominal pain, right? Control the diarrhea, control the constipation if those things are present, and basically decrease stress, right? So you're going back once again to all the things that can potentially put you at risk for IBS, right? So most of our things will probably be like lifestyle types of modifications, right? So it's the diet, avoiding food triggers, stress management, no alcohol, no smoking, no fluids with food, maybe, making sure that's balanced properly, right? If you have too much fluid with the food, you may end up with things like abdominal distension, right? So following whatever medications that the patient has been put on. So if they're constipated, they may have particular meds. If they have diarrhea, they're going to have particular medications. And then all the other complementary types of medicine, so this is the other alternative types of therapies even, can come into play here. And like I mentioned already, the dietary changes, figuring out exactly what it is that is the irritant, right? So for some patients, it's things like beans, coffee, corn, wheat, dairy, fried foods, alcohol, spicy foods, those types of things. So just keeping a food diary and trying to figure out, okay, when is it that my IBS really shows up, right? Making sure the patient is able to document all of that. And yeah, so relaxation, right? And some patients can actually get a decrease in symptoms for a while, and that to the point that this is no longer an issue. But the patients that don't really track and follow the regimen, that may not be the case for them. All right, so that's essentially it with IBS, guys. So just knowing that it's a spastic colon and there's no anatomic or structural damage necessarily. We're focusing on the theory of the fact that there's a dysregulation. In particular, we're highlighting serotonin signaling, or maybe there's infections or irritations or something else happening in the patient. And then understanding that the clinical manifestations basically can be anything. In addition, we've mentioned pain, we've mentioned that it could be either constipation or diarrhea or even both, and things like abdominal distensions. So essentially our treatment is going to be more so lifestyle modifications that need to be happening. And then we're moving on to malabsorption. So you're focusing on the word malabsorption. And if you're paying attention, like, I haven't really said anything new yet. Like, I'm sure you've had patients and we've said that they've had malabsorption. I'm sure you've had patients, or you've talked about patients in your previous semesters and we've said they had constipation, or we've said they had diarrhea. Maybe we didn't say things like, and for sure we've said they've had maybe fecal incontinence, right? Maybe we didn't necessarily use the words like IBS, right? But these terms are not new, and that's what you want to focus on, right? They're not new. You've come across malabsorption, diarrhea, constipation, incontinence way before this nursing 411, okay? So you're focusing on what the definition is in terms of all of these conditions. For now, we are with malabsorption specifically. So this is just the inability of the digestive system to absorb one or more of the major vitamins, minerals, or nutrients, right? And there's so many different things that can cause this malabsorption to happen. So maybe things like celiac disease, maybe things like Crohn's disease, maybe the patient is getting radiation and then now they have radiation enteritis, right? So it's just an inflammation in your lining basically from the radiation. It's just so many different things that can cause some of these malabsorptive disorders to happen, right? So here you're given some other conditions. So you have your mucosal transport disorders, and you don't necessarily have to remember these words. So an example for the mucosal transport disorders would be something like celiac disease, Crohn's disease, or something like radiation enteritis, right? So the other ones could be infectious diseases. Other ones may be described as luminal disorders. So paying attention to the word luminal. Once again, you don't have to memorize that word. But an example for this one might be something like, let me see, I'm looking at my notes here. So one example that I saw was that it could be specifically because of bile acid deficiency, or it could be because of chronic pancreatitis. Those might be considered some examples of luminal disorders. So no need to memorize whether it's mucosal or luminal. At this point, just know some of the conditions that can cause malabsorption. So it's things like celiac disease, Crohn's, chronic pancreatitis, and I would keep it that simple for right now. So once again, malabsorption is a problem. So what are you going to be seeing in the patient? So you may find things like diarrhea or frequent loose, bulky, foul-smelling stews, high fat content, and they're often grayish. So keyword is malabsorption. Things are not being absorbed. Fats are not even being absorbed and being digested and metabolized, all that good stuff, right? So that's why it's a malabsorption. So symptoms are going to mirror a lot of those that you find in IBS, right? So malabsorption. Keyword, once again, being that they're not getting the major vitamins, they're not getting the minerals, they're not getting their nutrients. So if that's happening, then there's a malabsorption. Is it possible that you're going to be seeing things like weight loss and vitamin or mineral deficiency? Absolutely, right? So all of that ties in together nicely. If this malabsorption basically stays untreated, then yeah, the patient's going to start looking weak, emaciated, because they're basically starving, right? And they're dehydrated. They're not absorbing their fast soluble vitamins, right? So this leads to a condition known as avitaminosis. So without vitamins, patients are not getting the correct nutrients that they're getting. All right. So remembering that literally when we say that the patient is suffering from malabsorption, we know that it's the inability of the digestive system to absorb one or more of the major vitamins, minerals, or nutrients. So then just think about, okay, if they can absorb all of that, then what is the end result, right? And we've been given some examples of conditions that can cause that. So the end result is you're getting this patient that is basically suffering from almost malnutrition at this point, right? Because they're starving. All right, so then for the medical management, you're avoiding dietary substances that aggravate malabsorption, and so what would that look like in terms of dietary substances that aggravate malabsorption? So try to think back under IBS, and remember that there's certain things that can be irritants, so things like coffee, caffeine, alcohol, smoking, those types of things. Those are not beneficial. They're not going to help with your absorption of nutrients, right? Those are not good. Supplement lost nutrients like the water-soluble vitamins, fat-soluble vitamins, and minerals. So maybe we have to be giving some things parenteral here as opposed to the enteral because the patient is not absorbing them. So is there a different way that we can potentially give them the vitamins that they're missing? Can we inject them or whatever? So the doctor has to figure all of that out. And if the patient's condition is caused by something like chronic pancreatitis, making sure that they're stopping drinking, right? And then the other stuff is giving antibiotics, antidiarrheals, and probiotics to basically help with the absorption management that needs to be going on. For the nurse, it's all about education. So some of it is fluid and electrolyte balance information that you need to make sure the patient knows, making sure they're drinking enough, and making sure they're reporting when they're having diarrhea, let's say, and then teaching about the risk of osteoporosis due to calcium malabsorption, right? So you see how everything is tying in together now. Nutrients not being absorbed, calcium not enough, the fact that they can end up with something like osteoporosis. So really, really paying attention to all of that. The assessment and diagnostic findings, just know that these tests are out there. One that I will mention now, but we'll know just to remember for later, is the Schilling test. So this is the one that's it's a test that's done to see whether or not you're absorbing vitamin B12 properly, right? So it's a test used to see whether you are absorbing vitamin B12 properly in the intestinal tract. So this is important when we're talking about anemias later on. All right, that's the only one I'm going to mention, but just know that these other tests are out there. The learning needs are going to target whatever the issue was that is leading to the fact that the patient now has malabsorption, right? So it's either vitamin replacement, dietary therapy, giving the patient probiotics. So other examples of probiotics even include things like yogurt, right? And I'm sure you've seen those good ones, like the organic ones, and they'll tell you that it has live cultures in there that are beneficial. And then considering fluid and electrolyte imbalances, and basically targeting that with the proper amounts of fluid rehydration therapy as needed. And then obviously giving the right calcium supplements and all those types of things to prevent things like osteoporosis if the patient is definitely at risk for that. And that's it with all of these really easy, loosey-goosey topics. And then we get into diverticular disease, right? So these guys are considered the acute inflammatory intestinal disorders, all right? And I'm going to give you like a little bit of a chart that's going to help you in terms of trying to remember some of these so you can keep everything in compartments to help you as you study. So some definitions. So a diverticulum is a sac-like herniation of the lining of the bowel that extends through a defect in the muscle layer. So sac-like herniations, you know, like a hernia is when your skin basically becomes weak, right? So a part of your skin is basically weak and then it's herniating out of its normal way that it should be, all right? So this diverticulum may occur anywhere in the intestine, but most common happens in the sigmoid colon. And then diverticulosis is multiple diverticula without the inflammation. So keyword is just locis here. And then diverticulitis is an infection and inflammation of the diverticular. And once again, the diverticular was a sac-like herniation of the lining of the bowel. So diverticular disease increases with age and is associated with the low fiber diet. So already you're seeing that somebody with a low fiber diet may be more at risk for diverticular disease. And they're going to find out whether or not the patient has diverticular disease by doing a colonoscopy. In terms of some of the assessment findings that the nurse might see in the patient, so what are you going to see? So once again, remembering that you have this sac-like herniation that's going on, right? And here we're highlighting the fact that the patient has diverticulitis, right? So going back to definition and noticing that here when we're saying diverticulitis, we are saying that the patient has an infection and inflammation of the diverticula, right? So what might we see in the patient? So once again, we might not see everything in everybody, but these are some of the usual things. So things like constipation, some patients may be asymptomatic, but they usually have some type of bowel irregularity. So things like nausea, anorexia, bloating, and abdominal distension. So for sure, depending on how advanced the diverticulitis is, you're going to be seeing some type of manifestations. So diverticulitis, symptoms include mild or severe pain in the lower left quadrant. So this is where I wanted you guys to start paying attention to the quadrants that are being affected. So here you're noticing this left lower quadrant, right? And things like nausea, vomiting, fever, chills, and leukocytosis. So leukocytosis is basically just pointing to the fact that the WBCs are extremely elevated, and this is definitely a sign of inflammation. All right. So any thoughts as to why now it's the left lower quadrant where the patient is complaining of pain versus some of the other conditions that we were looking at, maybe they were in the right upper quadrant? Like, was there a clue in how we were describing diverticular diseases, that's giving us a reason as to why it's the left lower quad that's being affected, right? So remember from your very first definition, or under diverticular disease, it says that it may occur anywhere in the intestine, but most common in the sigmoid colon. Could that be a potential reason as to why now we're worried about the left lower quadrant as being the reason why we're saying there's pain in that area? So you're going to be asking questions regarding the onset and duration of pain and the past and present elimination patterns. You're going to be looking at nutrition and dietary patterns, including fiber intake. You're going to be inspecting the stool and monitoring for symptoms which may lead to any types of complications. The main diagnoses under diverticulitis include things like constipation and acute pain. For sure, acute pain is way at the top of your list. And one of the other reasons for potential constipation could be because of the fact that the diverticular are basically herniating in the adult position. And then this condition could also lead to things like malabsorption potentially. So that ends up being an issue as well here. Your potential complications, so including things like perforation, and this may actually require surgery, right? So perforation and opening happens. Things like peritonitis, right? So we have peritonitis on another slide, right? So with this one, what are you seeing under peritonitis? So it's an itis, right? So peritoneum is basically now surrounded by, potentially bacteria that shouldn't have been there, right? So now you have this abdominal pain that you may see, rigid board-like abdomen that's happening, and then loss of bowel sounds potentially even, and maybe they're getting signs and symptoms of shock. That happens a lot with the peritonitis, right? And for sure with the perforation, you may see some of the same exact manifestations that are going on, right? And then abscess formation. So with that, what are you going to be seeing? So things like tenderness, a palpable mass, fever, leukocytosis, like really, really just a whole bunch of crazy things going on. And then one of the other complications is bleeding. So for sure, all of these can happen. It doesn't mean all of them will happen. Okay? So all you want to do here now is just figure out what's going on, and then basically just make adjustments to fix what's happening with your patient. So maintaining normal elimination pattern, so encouraging fluid intake of at least 2 liters per day, if that is okay for the patient, right? You're looking to see why did they end up in this situation in the first place. Do they need things like surgery? Just really just depends on what the patient needs. If they're constipated, it makes sense to give them some fluids, 2 liters, right? Giving soft foods with increased fiber, cooked vegetables, individualized exercise plan, bulk laxatives and stew softeners if they're constipated. That's the key word once again, right? So understanding that there can be so many different variations as to how this particular condition is showing up, but we do remember that for diverticulitis and some of the diverticular diseases, low fiber diet was really implicated as being a problem. So that's why you're seeing a lot of things here targeting either giving water, giving fiber, making sure they're moving so that the patient does not end up being constipated, right? So tying in all the dots, low fiber diet seemed to be the bigger issue as to why the patient is ending up with the diverticular diseases. We're moving on, and we are going into intestinal obstructions at this point. And all right, so key thing under intestinal obstructions is that you're paying attention to the fact that you can have intestinal obstructions being caused by either a mechanical obstruction or it can be described as a functional obstruction. So under mechanical, look at the word mechanical. This is because of a pressure on the intestinal wall, right? So some type of pressure is happening on the intestinal wall. And this pressure, this mechanical obstruction that happens is because of either stenosis, a stricture, or a neoplasm. So essentially, something is either closed off, it's too tight, or there's a mass. But because of that, then you're getting this pressure. So keyword is pressure. So mechanical obstruction due to pressure, all right? And then functional, something is supposed to happen, right? But it is not happening. So functional, something is supposed to happen, but it's not happening. So this is specifically because of an intestinal musculature cannot propel the contents along the bowels. So patients have particular conditions where the food is basically not able to be moved along. So food is supposed to be moving along and it is not being moved along. So that is the issue that's happening under functional. So we have mechanical versus functional. So you have to be able to understand the difference between the two. Okay, so there are certain things that can cause functional obstructions. You've been given examples here of muscular dystrophy as well as Parkinson's disease. All right, so there's the muscle is not contracting like it should be essentially, and the food is not being propelled forward. So that is the problem that's happening over here. The other big point to mention about the intestinal obstructions is the fact that they can be partial or they can be complete. So obviously if it's a complete obstruction, that is definitely worse than the partial, right? Because at least with the partial, some of the food or the contents that are supposed to be going forward, the digested products are able to still move. But if it's complete, this is why you can end up with like a megacolon and a huge impaction that happens, and even necrotic tissue because nothing is moving forward. All right, so obstructions can be partial or complete, and most of them happen in the small intestines. So now we are specifically highlighting the small bowel obstruction first, okay? So a whole bunch of different things can cause the small bowel obstructions. So could be adhesions, are the most common causes, but other things can be hernias, neoplasms, basically some type of cancer or weird growths, twisting of the bowel, and that's also known as volvulus. And so what's happening here is once you get the obstruction that's happening in the small bowels, the intestinal contents, so the fluid and the gas accumulate above the obstruction. So you're ending up with fluid retention. You're getting increased pressure within the intestinal lumen. You're getting things like edema, congestion, basically, not congestion, congestion, necrosis, maybe rupture or perforation. And if you're getting things like perforation, you can end up with something like peritonitis. So just think about it. There's an obstruction that's happening. Things are not able to move forward. So all these things are accumulating. So yeah, that's why you're getting edema, congestion, necrosis, potentially, and a perforation can happen. All right. The patient may also complain of things like crampy pain, colicky pain due to the peristalsis, both above and below the blockage. So things that are above the blockage are trying to get through, and the things that had potentially already gone through before the blockage are below it, and they're still trying to move forward. So it's just a very weird situation, right? So just a weird crampy pain because the normal mechanism is no longer there. So maybe the patient's passing things like blood and mucus, but none of the real fecal matter, right? Or the patient's not having the real gas that they need to be having, and the patient can potentially even vomit, right? So keyword, intestinal contents, fluid and gas accumulating above the obstruction, right? Getting fluid retention, weird things like edema. Major complications include like the necrosis and the peritonitis, right? But you're not getting no real fecal matter that's able to move forward. So this is why they're vomiting also, because all this stuff is just accumulating over here. Okay, so keeping it very, very, very simple. So already you're thinking, okay, well, if all this stuff is accumulating on top, what can we possibly do to get rid of all this accumulation that's happening, right? So you want to start thinking already, maybe, is this where like maybe an NG tube might even make sense? Okay. And it definitely does. So decompression of the bowel via the NG tube, right? And when they put in the NG tube, they remove all that stuff that's collecting, and that's going to improve the mortality, the symptoms, and minimize the risk for aspiration. If the bowels are completely obstructed, or even partially obstructed, then they may want to even consider things like surgical interventions. And the surgery will basically be to fix whatever the condition was. So if it was a hernia, then they'll do a hernia repair, right? If it's a hernia that was causing the obstruction, then they'll do a hernia repair. If it was a stenosis that was causing it, then they'll open that up, right? In some cases, the bowels are removed and then they end up doing what is known as anastomosis. So the word anastomosis just means that they're cutting off a piece maybe of the bowels, and then they're connecting whatever pieces are left, right? So we'll have examples of that in class that we'll be talking about. For the non-surgical patient, nursing management include things like maintaining function of the NG tube, assessing and measuring the output, monitoring fluid and electrolytes, nutritional status, bowel sounds, abdominal pain, and abdominal distension. Okay, so small bowel obstruction, once again, keeping it very simple. So we're doing intestinal obstructions at this point. We're looking at specifically at small bowel obstruction. We know that there's a whole bunch of different things that can cause it. We've been given examples of hernias, neoplasms, twisting volvulus that can happen, and the fact that the intestinal contents, fluid and the gases are accumulating above the obstruction. And right away we're thinking of the NG tube that can be put into place to relieve some of that. We know that the obstructions can be partial or they can be complete, and so depending on the severity, in some cases we may actually need to be the patient to have surgery, right? So depending on what they need, that's the treatment we're going to do. And then for the nurse, understanding the intake and output measurements being important, recording all of that, keeping on top of the nutritional status once whatever treatment has been done, and just making sure the patient is well hydrated as well, and knowing that the patient can vomit because of all that nasty stuff that's building up and not able to move forward. For the large bowels, if the patient has an obstruction, most likely is happening in the sigmoid colon, all right? And it's pretty much the same scenario in the sense that you're getting the accumulation of intestinal contents, the fluid and the gas proximal to the obstruction, which is just another way of saying above the obstruction, very similar to the small bowel obstruction. And if the blood supply is cut off, so the obstruction is really, really big, you can end up with things like intestinal strangulations and even necrosis. And these are basically considered life-threatening. So dehydration actually can also happen because the colon cannot absorb its fluid contents. So I apologize because this should say cannot absorb its fluid content. So sorry for the misspellings of words here. Because if you go back to the initial slides I gave you about what the colon does, you know, part of the stuff that it does is also with absorption of fluids, right? And then apparently adenocarcinomas, tumors account for a majority of the large bowel obstructions. So main takeaway in terms of the large bowels, primarily the large bowel obstructions happen in the sigmoid colon, and you're getting the accumulation of fluids above the obstruction once again. And also if this case is really severe, the patient can have the strangulation and necrosis. Main takeaways. Unlike the small bowel obstruction, the symptoms develop and progress slowly because it takes a minute for this to build up, okay? If the colon is involved, then constipation may be the only sign, all right? If the patient has blood loss, that can actually result in iron deficiency anemia. Patient may experience weakness, weight loss, anorexia, abdominal distension, crampy lower abdomen pain, and fecal vomiting may occur. And obviously here we're getting fecal vomiting because now we're all the way down, right? We're all the way down in the GI tract. All that stuff is collecting and the patient is throwing up. So that's why you're getting the fecal vomiting because we're much, 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 much lower. So medical management is restoration of intravascular volume, correction of the electrolyte abnormalities, NG tube aspiration and decompression needing to be done right away. Nothing different in terms of between small bowel obstruction and large bowel obstruction. Colonoscopy to untwist or decompress the bowel if that is needed. Cecostomy, which is a surgical opening into the cecum to relieve the obstruction, and this will help to relieve the gas and the drainage. They could put in a rectal tube. One of your colleagues in one of our last classes talked about seeing a rectal tube to decompress for area lower in the bowel. And then the surgical treatment primarily is to remove the obstruction, and in some cases the patient may end up needing a temporary or a permanent colostomy. So honestly, it really just depends on how the patient is showing up. And none of these treatments are weird or odd for you. The only one that's new is the cecostomy, which I'm pretty sure I'm not pronouncing the right way. But that's just a surgical opening into the cecum or to relieve the obstruction. And then the nurse is the same things that they were doing before. So monitoring the fluid and electrolytes, giving IV fluids, preparing the patient for surgery if needed, colostomy care if that's the case, and then just monitoring all the symptoms that are present in the patient. And that is actually the end of all the content. All the other stuff, I left it on here. Like the cancer PowerPoint slides I left, but you don't really need any of those. All right, so you are going to stop here. Yep, and